B-cell targeted therapies in the management of IgA nephropathy. Over to you, Jon.
Thanks very much, Sydney, and it's nice to see some familiar faces from about 10 minutes ago. So there will be more IgA nephropathy to talk about. But this time I'm going to focus on the B-cell directed therapies. So here are my disclosures. You saw this diagram previously. But when we think about what we might achieve by targeting B cells, we have the opportunity to target immune complexes. If we target B cells, we can reduce immune complexes. If we target B cells, we can target Gd-IgA1. And we can even give treatments, as we were discussing in the previous session, to target the mucosal immune system, the source of that Gd-IgA1. So targeting B cells allows us to target many of the key components of the pathogenic cascade in IgA nephropathy. So how can we do that? What kind of drugs might we have available? We could take the view that we actually want to target a whole immune microenvironment. So we could target the mucosal associated lymphoid tissue. We could say, actually, what I'd rather do is target individual subsets of lymphocytes involved in immunoglobulin production. We can target the T cells that provide co-stimulation to B cells to generate antibody. We could target the B cells themselves. Or we might target the plasma cells, the cells that ultimately terminally differentiate and generate immunoglobulin. All of those are potential targets. If we think about targeting B cells and plasma cells, we might take a B cell modulation approach. We might target those survival factors, BAFF and APRIL, that cause B cell and plasma cell proliferation and survival. We might say, actually, let's take an oncology approach. Let's just kill these cells. Let's deplete them. So we could go ahead and treat this disease with drugs that have been developed to treat cancer and kill the cells generating antibodies. Or alternatively, we may say, let's just forget about the cells altogether. Let's go straight for the antibody in the circulation and remove it. Just remove the antibody. All of these are potential options that are becoming a reality in the treatment of IgA nephropathy. So let's think first about targeting the mucosal immune system. We have a drug, Nefecon, specifically packaged to deliver budesonide in high concentration to the mucosal immune system of the terminal ileum, because we believe that is a major source of IgA that ultimately ends up in the kidneys. So that's a way. We don't quite know which cells the budesonide is impacting upon, but we do know that taking that approach is clinically efficacious in reducing proteinuria and preserving kidney function. And we now know that it is capable of targeting those B cells that produce the pathogenic form of IgA. So here's some data we presented at the ERA this year, where we looked at the entire NefIgArd cohort. And what you can see is that targeting the mucosal immune system of the gut reduces those Gd-IgA1 molecules, reduces immune complex, reduces the antibody that recognizes the Gd-IgA1, and reduces the level of immune complexes. So targeting the whole mucosal microenvironment is capable of targeting pathogenic IgA. But there are other approaches. How about targeting individual cell types? So we could target the T cells that provide co-stimulatory support. And indeed, there are a whole range of drugs that are being evaluated in a range of autoimmune diseases, and in particular transplantation, that are designed to block T cell help for B cells and antibody production. And this has not been explored greatly in IgA nephropathy. There has been a small study that some of us here were part of, looking at blocking CD40 ligand, CD40 co-stimulation. And that was with a drug called tegoprubart. It was a small proof of concept study. It did show some signs of efficacy, but the company decided not to take it forward in IgA nephropathy and have actually developed this drug now in transplantation. We could take the approach, as I said, that we're just going to target B cells and plasma cells, and we might take a modulation approach, or we might take a killing approach. If we think about the modulation approach first, the two cytokines we're going to target are BAFF and APRIL. They're important, as I say, in B cell and plasma cell survival and proliferation, and importantly in IgA class switch recombination. The largest genome-wide association study that's now been published, as part of the data analysis, identified proteins in the BAFF-APRIL cascade as being genetic risk factors for the development of IgA nephropathy. So there's a genetic basis for why we might want to target this system. And you can see here that these cytokines act through cell surface receptors, and perhaps more clear on this side, you can see that APRIL acts through BCMA and TACI, while BAFF acts through the BAFF receptor alongside TACI and BCMA. And we have 5 drugs that are currently in development, 2 that target APRIL only, and 3 that target BAFF and APRIL. So if we think about the monoclonal antibodies that target APRIL, we have sibeprenlimab, and we have zigakibart or BION 1301. Both of these are in phase 3 studies. Both have had early phase studies published as well. So as I said in my previous talk, we have data for sibeprenlimab from the phase 2 study published, and this was published to coincide with the ASN a couple of weeks ago. And what we saw in the phase 3 trial was that targeting APRIL, blocking B cell activation, reduced Gd-IgA1 and reduced proteinuria. We don't know the GFR data yet, but that data was sufficient to get this drug approved in the United States. And the likelihood is this drug is going to be available in the Asia-Pacific region within the next 12 months. So you are going to be able to block B cell activation with an anti-APRIL monoclonal. We have phase 2 data for zigakibart, early phase data, no data from the phase 3 yet, but data showing that this approach can also reduce Gd-IgA1 and proteinuria. And then we have the agents that target BAFF and APRIL, atacicept, telitacicept, and povetacicept. The most advanced of these is atacicept. We have phase 2 data, and if you were at the industry symposium where Sydney and I talked earlier in the day, we talked a lot about atacicept and BAFF and APRIL, but we have phase 2 data. We have long-term data out to 96 weeks now, published, and to coincide with the ASN, the interim analysis of the phase 3 Origin study was also published, showing that blocking BAFF and APRIL reduces Gd-IgA1 and reduces proteinuria. Again, we need to see GFR data, and all the data for atacicept is now sat with the FDA, and this drug is likely to be approved at some point in 2026 and making its way to Asia-Pacific at some point in 2026-27. So these drugs are going to be a reality for you over the next 12 to 24 months. Telitacicept is only being developed in China. They presented their data at ASN, showing that this drug, like atacicept, reduces Gd-IgA1, reduces proteinuria, and they presented some GFR data showing that it stabilized GFR. Only going to be available in China. Is already approved to treat lupus nephritis in China. And then povetacicept, we don't have any phase 3 data yet, but there's early phase 2. But if we take that aside and say, actually, what we really want to do is we want to kill these cells. We want to take an oncology approach. So how might we do that? Well, there's lots of ways we can target B cells and plasma cells to kill them. That's what the hematologists do when they treat lymphoma, they treat myeloma. Lots of different ways. If you want to be very aggressive, you could take a CAR T cell approach. You can see here CAR Ts targeting multiple cell surface receptors and have been developed and used to treat hematological malignancies and are coming into autoimmune kidney disease. There are trials and data now for CAR T therapy in lupus nephritis. Not seen anything in IgA nephropathy yet, but it's not to say it won't come. We could take an approach with small molecules that we're going to block the system that actually the signal transduction pathways that are activated when B cells meet their antigen. And we've got a whole series of kinases, Bruton tyrosine kinase, spleen tyrosine kinase, LIN, that have small molecule inhibitors.
currently being used to treat lymphomas, potentially making their way into autoimmune disease. And we tried one of these in IgA nephropathy. We have conducted a small study of fostamatinib, which blocks spleen tyrosine kinase. There was some evidence of efficacy, but the company that owned the drug didn't want to take it forward in IgA nephropathy. But these agents may be coming. Another approach that has been tried is the use of bortezomib, a proteasome inhibitor. For any of you that see patients with myeloma, Velcade is a common treatment for myeloma. It's been tried in IgA nephropathy. A very small study here showing that there was some evidence of reduction in proteinuria, but it's got a drug with lots of toxicity and it's not been taken forward. But you can see the pattern here. Look at what the hematologists have and see whether we can use it in autoimmune-mediated kidney disease. Where there's been most interest and most progress is in using monoclonal antibodies that target cell surface markers on B cells and plasma cells. And perhaps the best one that we use in clinical practice is rituximab, where we target CD20. Standard treatment for membranous ankylosing. You may well have seen data for obinutuzumab that has now been shown to be efficacious in lupus nephritis. So CD20, nice straightforward marker, doesn't work in IgA nephropathy. And that's likely because the cells that are causing the production of pathogenic IgA are within the mucosal immune system. They're not sat in the bone marrow. Rituximab is very good at killing cells that are in the bone marrow, which is where most autoantibodies are generated. IgA nephropathy is different. And it's likely the reason rituximab doesn't work is because it is not effective within the mucosal microenvironment because of the presence of high levels of survival factors like BAFF and APRIL. But there are two monoclonal antibodies currently being evaluated in phase 3, and these target CD38, which is present on B cells, but much more expressed on plasma cells. And of course, daratumumab, a drug that is commonly used to treat myeloma, is a CD38 depleter. And here we have two CD38 depleters, felzartamab and mezagitamab, that are currently in phase 3 clinical trials. We have early data in IgA nephropathy, so the phase 2 data for the IGNAS study has been published. And here's data I presented at the ERA conference earlier this year for mezagitamab, and this data will be published soon. And what's interesting about these drugs is that you have an upfront treatment over the initial 22 weeks, and then you have a treatment holiday. And what you see with this drug, bearing in mind it's a small study, single arm, is that over the period of time off treatment, there is a sustained reduction in proteinuria and a sustained reduction in Gd-IgA1. And we now have data out to 96 weeks. So these are a new type of therapy, only at the very beginning of phase 3, but are going to give us another option. So we have all these ways of targeting the cellular immune system. How about just dealing with the antibody in the circulation? That would be quite effective, wouldn't it? If we could remove the antibody and leave the cellular immune system alone, that might get around some of the potential risks of chronic immunosuppression. And so how might we do that? Well, there are a number of different approaches. The first is we could leverage the neonatal FC receptor, where we can tag the circulating IgA with a protein that then targets that IgA to endosomes. Those endosomes move the IgA into lysosomes where it's degraded, and you remove IgA from the circulation. It's already being used to treat IgG autoantibodies. So here is efgartigimod. It's approved to treat myasthenia gravis, an IgG autoantibody-mediated disease. And what you can see here is the efgartigimod binds to the IgG, directs the IgG into the cell where it is degraded. Could we do that with IgA? There is another approach where you tag the Gd-IgA1 with a drug, and you tag it to bring it to the hepatic acyl-glycoprotein receptor, where the IgA is endocytosed and degraded. We already have healthy volunteer data, and we have a clinical trial of this approach already happening in IgA nephropathy. And in fact, my site will open for this trial later this month. So a way of removing the Gd-IgA1 exclusively. And then we have protease therapies. Bacteria produce proteases that digest antibodies because bacteria use that to evade the immune system. We have IgG proteases, we have IgA proteases. There's already data in experimental animals that if you give an IgA protease to an experimental animal with IgA nephropathy, you take out all the IgA in the circulation, you also digest the IgA already stuck in the kidneys. Could that be a possible new approach? We already have an IgG protease, imlifidase, that is approved to treat patients ahead of transplantation who are highly sensitized. It takes all the IgG out of the circulation at the time of transplantation. So could this be an approach that's going to happen going forwards? It may well be. So we have all of these wonderful approaches that are coming that will allow us to target the pathogenic IgA. And so if I was going to advise any of the younger nephrologists in the audience, what would be the next conference or training course you'd go on? I would suggest you go to the European School of Hematology, because everything I've talked about has come from the hematologist. I'm married to a hematologist. She loves telling me of all the great new drugs they have and saying, why don't you have them? Because we are going to be taking those drugs to allow us to kill B cells and plasma cells to get rid of those pathogenic antibodies. And so we have as our goal to stop the formation of immune complexes, stop this, and treat our patients. And we've seen an evolution of how we can achieve that. We've had the sledgehammer approach, cyclophosphamide, high-dose steroids, very non-specific, lots of side effects. We're now getting to steal drugs from the hematologists, targeting CD38, etc. Where might it be next? Well, we're already seeing genome-edited B cells. Could it be that we will use gene therapy to reprogram B cells in patients with IgA nephropathy to stop them producing pathogenic IgA? Could that be on the cards? It could be. And so I come back to the KDIGO guideline, which is what we have at the moment. We've already started to look at a B cell-directed therapy that is targeting the mucosal microenvironment, and this is likely to increase as we get more therapies. So what I would expect to see and hope to see is that in the future, and you're going to get bored of this slide, we are going to see lots of changes. But at the center of everything we do for IgA nephropathy will be targeting B cells and the production of pathogenic IgA. So thank you very much for listening. And I think there's about a minute for questions.
Okay. Thank you, Professor Barratt, for that comprehensive talk for B-cell targeted therapy. I'm Dr. Tseng, Ching from National Cheng-Kung University Hospital in Tainan, Taiwan. Okay. Thank you. Now it's my now it's my great pleasure to introduce our second speaker, Professor Hitoshi Suzuki, Chief of the Department of Nephrology and Hypertension at Juntendo University, Urasayasu Hospital, and the Professor of Nephrology at the Juntendo University School of Medicine in Japan. He is internationally recognized for his pioneering work on the pathogenesis of IgA nephropathy, including galactose deficient IgA1, immune complexes, and mucosal immunity. Today, he will speak on ameliorating complement-mediated injury in IgA nephropathy. Please welcome Professor Suzuki.
So thank you very much for your kind introduction. And first of all, I'd like to thank the chairs and also the scientific committee member of APCN and TSN. So give me such a great opportunity to talk here. So this evening, I would like to talk about ameliorating complement-mediated injury in IgA nephropathy. Sorry, so I cannot pronunciation in Chinese, but you know. next. So this is my COY. So multi-hit model of pathogenesis for IgA nephropathy indicating as a hit 1, the increased level of the serum level Gd-IgA1 and Gd-IgA1 forming immune complex with Gd-IgG and large immune complex and deposit in mesangial area. And following the mesangial deposition of IgA containing immune complexes, the complement activation occurs, which drives and amplifies glomerular inflammation and damage. The complement activation is necessary. So glomerular co-deposition of C3 with IgA is detected in more than 90% of kidney biopsy in patients with IgA nephropathy. However, usually the C1q is negative in most of the patients with IgA nephropathy. So then complement activation is mainly the alternative pathway and lectin pathway. So our question is, what is the extent of the role of complement? Truly only the inflammation or more fundamental role in pathogenesis? So complement activation is ongoing active injury or resolving injury. And should we use the complement assays or histological staining to guide the therapy? And there is a limitation of the current complement measurement available to clinicians. So how is the complement system activated? So IgG have the pro-inflammatory and anti-inflammatory activities depending on the engagement of the Fc gamma receptors and the activation of the complement system depending on the IgG subclasses, glycosylation, and antigen density. So usually the IgG1 and IgG3 subclasses activated the complement system. So initially, the IgA nephropathy was described as an intercapillary deposit of IgA and IgG. However, not all of the patients showing the glomerular IgG deposition by regular clinical immunofluorescent analysis, as shown here. So this is a paper from the Dana's risk data. So routine immunofluorescence microscopy failed to detect IgG in many kidney biopsies from patients with IgA nephropathy. However, they analyzed the IgG molecular integrity confirmed by SDS page using the extract from the kidney. So then this extracted IgG bind to the Gd-IgA1. And also, if the nanobody is specific for the CS3 domain on its FC portion detected IgG in all patients with IgA nephropathy. If it is true, the IgG just activated immune complement system. However, there is a possibility of the IgA also have the ability to activate the complement system. So polymeric IgA bind to MBL via the carbohydrate recognition domain of the MBL. So MBL bind to the mannose and glucagon in a calcium-dependent manner. And this data indicated the IgA divided two portions, monomeric and polymeric IgA. So polymeric IgA had predominantly the Gd-IgA1 by HA lectin assay. So this polymeric Gd-IgA1 bind to the MBL and associated with the C4 deposition in the kidney. So the IgA activated also the alternative pathway. So this is kind of the old paper, but they said polymeric IgA is capable of activating the alternative pathway of complement. Then we would say the Gd-IgA1 immune complex deposit in the mesangium and activate the both alternative pathway and lectin pathway. So this is a detail of the complement pathway in the alternative pathway or lectin pathway. So let's think about the involvement of the alternative pathway in IgA nephropathy. So factor B is a key mediator of the alternative pathway. So as shown here, the serum levels of factor B is increased in patients with IgA nephropathy compared with other glomerulonephritis, and the serum factor B associated with proteinuria, and the serum factor B inversely correlated with eGFR. So we see the active case of the IgA nephropathy, the C3 and also FHR5 deposit in the kidney. So if we think about the alternative pathway activity, so we need to think about factor H and complement FHR5. So that is because if the complement is activated, so inactivation of the complement system by factor H, and CFHR compete with factor H to activate the complement system. So the GWAS data also indicated the complement activation. So GWAS study have identified CFHR1 and 3 as candidate gene, and it is known that the CFHR1 and 3 deficiency suppress the progression of the IgA nephropathy and reduce the glomerular C3 deposition. So this data it also indicated the competition of the factor H and CFHR. So if the levels of CFHR increase, the suppress the factor H. I'm sorry, this is Japanese. This is control. And CFHR increase in the IgA nephropathy patient, and also in the active case of the IgA nephropathy, it's shown the higher level of the CFHR. And the serum levels CFHR5 levels are elevated in the IgA nephropathy and correlate with the renal prognosis. Interestingly, the CFHR5 levels increase from the disease early onset stages where the renal function is preserved, such like the CKD stage 1. And also CFHR5 levels correlate with the active cases of region, such like the E1 and the C1 and C2 region. So next, think about the involvement of the lectin pathway in IgA nephropathy. So to think about the lectin pathway, we need to think about MBL, picorin, and MASP, and C4D. So in this paper indicated that there is MBL, picorin, and MASP, and the C4D is positive in the glomerulus. However, this such like the active lectin pathway is shown in just 25% of the patient with IgA nephropathy. So this active lectin pathway indicated associated with Oxford M lesion and E lesion and global sclerosis. However, the glomerular C4D positivity rate is highly variable, 90% to 65%. However, the same data indicated the C4D positive in glomeruli is well associated with poor prognosis in kidney. So meta-analysis also indicated glomerular C4D positivity is associated with a decreased renal function and severe proteinuria, and also the severe histological lesion. So mannose binding lectin MBL deficiency and high levels of the MBL had a poor renal prognosis. And there is a non-linear association between the MBL levels and adjusted hazard ratio of 50% of eGFR decline or the ESRD. So then the next question is the complement activation happen in circulation or in the kidney. So this is all the paper, but the C3 is present in IgA1 containing circulating immune complex of the patient with IgA nephropathy. So IgG-C3 containing immune complex were detected in 24% of patients and correlated with the level of the IgA-C3 containing immune complex level. However, the IgM C3 containing immune complex were elevated only just 9% of patients with IgA nephropathy. So recently, such like the paper is published in scientific report. So the CFHR1 is positive in many cases of the IgA nephropathy patient. And circulatory IgA containing immune complex of patients with IgA nephropathy have a greater abundance of complement protein CFHR1. And after the immunosuppressive treatment, this CFHR1 level dramatically decreased. So complement proteome found in glomerular and circulatory IgA containing immune complexes. So it is suggested an association of complement regulatory proteins such as CFHR1 with pathogenic IgA containing immune complexes. So several techniques can be used to interrogate complement in affected patients with IgA nephropathy. So I already explained about the genetics and the tissue staining and the complement biomarker. So next, I would like to introduce some drugs. There are several positive clinical trials of complement inhibitory drugs have been reported. So this slide shows the complement inhibitory drugs and their target in the lectin pathway and alternative pathway, and also the terminal pathway of complement system. So iptacopan is a factor B inhibitor. This data indicated phase 2 study. So after the 3 months and 6 months treatment of iptacopan, the proteinuria reduced about 30 to 40%. And eGFR after the treatment with 3 months and 6 months. So in the treatment group with iptacopan, maintained eGFR compared with the placebo. So recently, the phase 3 data of iptacopan was published. The proteinuria at the 9 months of treatment iptacopan, so reduction of proteinuria about 45%. And this is important thing is adverse event is very similar between the iptacopan group and the placebo groups. And after the treatment with iptacopan, of course, the plasma levels of factor B decreased, and the C5b9 is the marker of the terminal pathway of the complement system. So after treatment with iptacopan, the urinary C5b9 dramatically decreased. So next, I would like to introduce the cemdisiran. This is RNA interference therapeutic that suppress hepatic production of complement component 5. So this is phase 2 trial data. So after treatment, cemdisiran, the proteinuria reduced about 37%. So of course, C5 level reduced about 99%. But hematuria also improved in 77% of patients with IgA nephropathy at the 32 weeks of age. So avacopan is a C5a receptor selective inhibitor. So this is an open label pilot study data. So after treatment avacopan, the proteinuria reduced 25%, and the urinary MCP1 levels decreased about 30%. So just recently, the labriximab data is published in JSON. So after the treatment, labriximab, the proteinuria reduced about 42%. And if we think about the eGFR slope compared with the placebo group, the labriximab maintained the eGFR slope. So this is just a phase 3 clinical trial concerning the complement inhibitor. So iptacopan and cefaxifene and labriximab is ongoing. So we would expect the efficacy and also safety data in this phase 3 trial. So this is a summarized data slide. The treatment target in IgA nephropathy and the positioning of drugs. So Professor Jonathan Barratt already explained about the upper part of the pathogenesis of IgA nephropathy, controlled of the B cell maturation. So after the deposition of IgA containing immune complexes, we would like to reduce the glomerular inflammation. In such a case, a systemic glucocorticoid is effective. However, recently we have another tool to inhibit complement activation, such like the factor B inhibition and also another anti-complement treatment. So we would expect the efficacy and also safety data. So thank you very much for your kind attention. Chee.
Thank you very much, Hitoshi, for your comprehensive review of the role of complement in IgA nephropathy. We will leave the Q&A towards the end of the session. Thank you. So I would now like to call upon the next speaker of the session, Dr. Cheung, also from the University of Leicester, and he's going to talk to us about the precision nephrology in IgA nephropathy from molecular insights to targeted therapy. Welcome, Dr. Cheung.
Thank you, Sydney. And just following on from those fantastic talks, I'm going to take a much more practical approach, linking those molecular insights into the targeted therapies that we have available now. Here are my disclosures. So I'm going to start off with a case. This is a case that I saw fairly recently in clinic, a 34-year-old woman, nursery worker, Caucasian patient, with a history of asthma and migraines, on no regular medications, and she saw her GP or a primary care physician after noticing some blood in her urine after an upper respiratory tract infection. And it was noted her eGFR was 52 on presentation, and the last time she had any blood done was around 4 years before, when her kidney function was completely normal. She was hypertensive, she had blood and protein on her dipstick, her PCR showed about 3 grams of protein per day, and she was referred through, she started on ramipril, and a kidney biopsy was arranged. So I think a case that will sound very familiar to many of you in this audience. She had a kidney biopsy done, she had 14 glomeruli on that kidney biopsy, but you can see half of those had evidence of scarring. So 5 had global sclerosis, 2 had segmental sclerosis, which indicates there's already chronic damage happening to around half the glomeruli affected within that kidney biopsy. Most had evidence of mesangial hypercellularity. 5 out of 14 had endocapillary hypercellularity. There were no crescents or fibrinoid necrosis, and there was interstitial fibrosis and tubular atrophy affecting about 10% of the biopsy. So that gave her an Oxford classification of M1, E1, S1, T0, C0, and she had evidence of IgA and C3 deposition on the kidney biopsy. And as Hitoshi mentioned, that finding of C3 and evidence of complement activation can be found in the majority of our patients with IgA nephropathy. So just going back to the case, I think the things to highlight with this case, again, a very typical case that we see. This is a young woman, aged 34, and we have to think about protecting that kidney function for the next 40, 50 years. And also, she's already lost a significant amount of that kidney function before we can even escalate and start therapy on her as well. So there is an urgency to treat in this patient. So we put her characteristics into the risk prediction tool, and this showed that she had a 50% decline, risk of a 50% decline in GFR or kidney failure at around 30%. So around a 1 in 3 chance of reaching those endpoints within 7 years. So she was reviewed in clinic, her ramipril had been titrated up in the meantime, her blood pressure improved, but she still had significant amount of proteinuria. And the question mark is what to do next in this patient with all these therapies that we have coming or available to us right now. So we don't have to go back very far, only 4 years ago, and this was the algorithm that we could consider. We could consider enrollment into a clinical trial because of the number of promising trials in this area. But beyond that, we could think about steroids, but we know that there are significant toxicities with those and not much evidence in Caucasian patients. But since then, we now have the approvals for several new therapies. There are SGLT2 inhibitors in non-diabetic CKD. And there are now approvals, as Jonathan mentioned before, of targeted release budesonide, sparsentan, and the FDA have now approved iptacopan, atrasentan, and very recently sibeprenlimab as well. Now, we heard talks this morning about SGLT2 inhibitors. Clearly, they have a beneficial effect on all forms of CKD, including IgA nephropathy. And here's the post hoc analysis from the DAPA-CKD study showing that dapagliflozin could effectively reduce the risk of 50% decline in kidney function, kidney failure, or death due to cardiac or renal causes. But here I want to show you that the rate of kidney function decline, it is slowed on dapagliflozin, but patients are still progressing at around 3.5 mils per minute per year in the dapagliflozin arm in the DAPA-CKD study. So definite room for additional therapies to be added on top of this. This is the data from the RADAR study. I'm sure many of you are familiar with this. Again, showing the poor prognosis with our patients with IgA nephropathy, over 80% of the cohort reaching kidney failure within 30 years of their diagnosis. And in fact, there have been subsequent analyses of RADAR showing that the only disease that progressed faster than IgA nephropathy out of the 20 diseases studied was anti-GBM disease. So diseases like ANCA vasculitis had a much better prognosis, and that probably speaks to the more effective therapies that are available at that time for that condition. And it's important to note that the risk calculators only predict a short-term risk over a 7-year period. And we have to think about the rest of that patient's life and the risk of developing kidney failure over the lifetime of the patient. Again, RADAR showed, and John mentioned this in the plenary talk earlier on, this strong association between proteinuria and kidney failure. And again, even low levels of proteinuria are associated with risk, with 20 to 30% developing kidney failure in the group that had a proteinuria level less than 1 gram per day. And in terms of GFR targets, RADAR showed us that we need to be targeting that eGFR decline to as low as possible and at least less than 1 mil per minute per year for the rest of the patient's life. And this is where the new KDIGO guidelines have pointed to that we want to be diagnosing our patients earlier. So there's a recommendation now to consider a kidney biopsy in any patient where you're thinking about IgA nephropathy and the proteinuria is above 0.5 gram per day, in light of that RADAR data showing that these patients are at risk. So lowering that threshold that we may have had before. And then think about patients at risk, that threshold being 0.5 gram per day. So think about escalating treatment or starting treatment above that threshold with the goals in mind to reduce the rate of loss of kidney function to less than 1 mil per minute for the rest of the patient's life and reducing proteinuria as much as possible. 0.5 grams per day as a target, ideally less than 0.3 grams per day, but accepting that in some patients that may not be possible due to underlying scarring. And this diagram's already been shown as well, and we have to target both these aspects, the IgA-mediated aspect and the generic responses to that kidney damage that drives glomerular hyperfiltration and maladaptive responses and proteinuria. So an IgA element and a CKD element as well. So Hitoshi showed this before, this current thinking on the 2025 paradigm, and that's to target both of these causes simultaneously, the IgA-specific drivers and those generic responses to IgA-induced nephron loss. So we can think of those two aspects at the top, which have been covered. So reducing pathogenic IgA and those immune complexes, reducing the consequences of IgA deposition and that glomerular inflammation. But we mustn't forget this aspect as well, because most of our patients have evidence of chronic kidney disease, kidney damage, and we must protect against that ongoing progression of those processes. And the goals here being in the middle as well, eGFR slope less than 1 mil per minute per year and proteinuria as slow as possible. So in the top bar here, we have Nefecon that's been approved. This was tested in the NefIgArd study. So just to go through this again, so patients spent 9 months on treatment versus placebo with another 15 months off treatment. Here you can see proteinuria falling by 9 months. It falls a bit more when patients are off treatment down to 12 months. And then there's a gradual return back to baseline. And it's important to note that by 3 months, there is no reduction in proteinuria compared to the placebo group. So we always say to patients, expect to be on a 9-month course and not to see any changes too early on. And you can see here, while patients are on treatment with Nefecon, that kidney function remains completely stable. It's when you stop it is when kidney function starts to fall at the same rate as the placebo group. But at the end of the trial, there was around a 5.9 mils per minute difference between the two treatment arms. Here's work done again in the laboratories in Leicester, led by Jon, showing this reduction in Gd-IgA1 levels to around 34% compared to baseline, and then they return back up to baseline once treatment is stopped. But having this immunomodulatory effect on those Peyer's patches and B-cell production of IgA. And patients do report some steroid-related side effects in a proportion of patients, maybe around 10 to 15%, affected by symptoms such as peripheral edema, hypertension, muscle spasms, and acne. But most of these were mild or moderate in severity. And we believe that the equivalent dose of Nefecon 16 milligrams per day is around prednisolone 8 milligrams per day. And we've now seen this out in the real world, and it's obvious that some patients do develop quite steroid-related side effects and very sensitive to that small dose. And in those cases, we may need to reduce the dose that we give them. Next, we have treatments to address the more CKD element. Here we can think about lifestyle measures important for our patients, all our patients with IgA nephropathy. Consider RASI, SGLT2 inhibitors, and more recently, endothelin receptor antagonists as well. And so if you look at the control arms from recent trials in IgA nephropathy, it's clear that there is a range of progression in the control arms of these trials. And some of the slowest progression here you see in the PROTECT study, we're only progressing at around 3.8 mils per minute per year, compared to the more faster progression you've seen in Sanctuary or the other phase 2 or phase 3 clinical trials. And the difference is with the PROTECT trial that there was a forced up titration of irbesartan, and 97% of patients reached the maximum dose of irbesartan within that trial. So I think there is much more that we can do with supportive care and to optimize that for our patients. We know that once IgA is deposited, that there is increased release of angiotensin II and endothelin 1. These are vasoactive peptides which have strong effects at increasing efferent arteriolar constriction and increasing glomerular hyperfiltration, hypertension, and therefore having this damaging effect and increasing proteinuria. But there's also good in vitro and in vivo evidence that show that both these molecules can drive mesangial cell proliferation, inflammation, production of inflammatory cytokines, and also have effects on podocyte architecture and the podocyte cytoskeleton, increasing tubular interstitial inflammation and injury, and having effects on infiltrating immune cells as well. So both of these peptides, angiotensin II, endothelin 1, having this synergistic effect. And up to now, we've only had the ability really to block angiotensin II signaling with ACE inhibitors, ARBs, but with the advent of more selective endothelin A receptor blockers, we can now target this process as well. And this was tested in the sparsentan PROTECT study, which showed that treatment with sparsentan could effectively reduce proteinuria in the sparsentan group versus the irbesartan group, could slow down that rate of progression of kidney function decline, and there was a reduction in the numbers of patients reaching a 40% reduction in EGFR kidney failure or death. And we have tested as well sparsentan in a mechanistic study called SPARTAN, where we use sparsentan as a first-line treatment. And in that study, we've looked at urinary biomarkers, and we showed a reduction in the urinary soluble CD163, a marker of activated macrophages within the kidney. And also, we've done repeat kidney biopsies within that study, and we hope to present that data in future conferences. Safety, this drug was well tolerated, very even numbers of adverse events. The main safety signal was of hypotension and dizziness, and much of this is due to the ARB component, and there was some peripheral edema which was managed with diuretics in the study. So the drug appears very safe. It's important to counsel women if you're using this drug, because if they are women of childbearing age, it's important to use effective contraception because endothelin blockers have known fetotoxic effects. Now, atrasentan is a specific endothelin A receptor antagonist. This has been studied in the ALIGN study. This recruited 340 patients and added on atrasentan on top of standard of care therapy. And there was a separate SGLT2 inhibitor arm who were on SGLT2 inhibitors at baseline, around 64 patients. And patients were randomized on a one-to-one basis to receive atrasentan versus placebo on top of standard of care. And then patients spent 4 weeks off treatment and then have entered into an open label extension period. So this study is still ongoing. The proteinuria data has been read out at week 36. And this showed, again, a significant reduction in proteinuria at that time point by about 36% compared to the placebo arm. And again, that proteinuria fall happens very rapidly within 6 weeks and is continued throughout the study period. Now, we're still waiting for the eGFR results, and hopefully we'll see those at some point next year. This was very well tolerated, again, very even numbers of adverse events between the two groups, and no difference really in study drug discontinuations as well. Next, we have glomerular inflammation, and options here would be systemic steroids or complement therapies, and Hitoshi has covered these very nicely in his talk. We know the complement system is activated in the majority of patients with IgA nephropathy. Here's data from Korea showing that in patients with baseline higher intensity of C3 staining, they have a worse kidney survival compared to those who are C3 negative. And this is out to around 10 years of follow-up. So I won't go into that in more detail. And Jon as well has covered the B-cell therapies, the very exciting therapies here, anti-APRIL, anti-BAFF-APRIL, and anti-CD38, which can target that pathogenic IgA. Finally, the big question, I think, is how long do we need to continue these treatments for? Can we taper them? Do we have to maintain them? Do we do cyclical dosing? It's clear, I think, from the APRIL and the BAFF-APRIL therapies that when you stop them, eventually the Gd-IgA1 levels will go back up to baseline, and then the proteinuria and the GFR features will return back to the previous disease trajectory. So I think we still need more data about what happens when you stop these therapies, but this will be a big question for the future as well. But in the bottom arm, it's clear that we'll have to continue these measures to retard the progression of that CKD that the majority of our patients will present with as well. So just showing this diagram again, published last month, really important. And the important change now is to target both of these aspects simultaneously. So moving away from that stepwise approach, which was in the guideline around 4 years ago, but into treatment of these two aspects up front. And this is what we did with my patient at the start, which I presented earlier on. And perhaps this will be the near future as well. We have more and more options, and I've not fitted all of these into this diagram, but we're going to get more and more options down each arm to tackle both the IgA-specific drivers and the consequences of that IgA deposition as well. So I'm going to finish here and say that the long-term outcomes from IgA nephropathy are currently poor, but the treatment landscape is rapidly changing. We do need earlier diagnosis, but importantly also to initiate therapy more aggressively and more early in our patients as well, given that disease trajectory that we've seen. And we need treatments that are safe and effective in the long term. The new guidelines recommend targeting both of these drivers simultaneously. But there are several unmet needs. We need to think about those populations that have been excluded from clinical trials, children, recurrent IgA after kidney transplantation, those with more advanced kidney disease, for example, GFRs less than 30. Are these therapies going to be as effective in those groups? How about those with rapidly progressive IgA nephropathy or chronic IgA that have been excluded from the clinical trials to date, or IgA vasculitis as well? Of course, the elephant in the room is the cost and accessibility of all these new therapies as well. I'm going to thank you for your attention. I'd like to thank all the investigators, site staff that have been participating within these studies, patients and carers, and also thank Novartis for sponsoring this KDIGO session. Thank you very much for your attention.
I thank you, Professor Chang, for your very clear and comprehensive talk. Now we would move our session to question and answers. A panel discussion. Yeah. We invite our three distinguished speakers to the stage. Any question from the audience, you can put into our online system for the answers.
So while you're thinking of the questions, maybe we can just start off with the questions that we have received online. If you have further questions, you're welcome to also enter your questions online, or if you want to speak up, we'll bring a microphone to you to ask the question. So the first question is directed to Jon on your talk, which is whether it is comparable to use steroid alone or it's interesting, the steroid plus Casablanca on the screen. So is it comparable to just use steroid alone or to use a combination of steroid plus something else for the patients?
So I guess if we come back and keep it simple, what we're trying to do is to preserve kidney function. And we want to preserve kidney function in the safest possible way, and with a combination of therapies that achieve that are available and accessible to you as a doctor. I think at the moment, the data would suggest that of the treatments that we have that modify the immune system, the drugs with the most toxicity and poor tolerability are systemic steroids. My preference is to use a targeted treatment that is safe and well tolerated. And so I would suggest that we would use a targeted release budesonide, so Nefecon, to manage the gut. That's what we have available. Whether we would want to combine that with other treatments, I think is something that we do need to think about and we need to test. My guess is, and I'll ask you, Sydney, this, because you have published a lot on mycophenolate, is for a Chinese population at very high risk of progression, it strikes me that something that would be very interesting to look at would be mycophenolate combined with gut-directed steroid as a way of maximizing control of the immune system, and potentially using hydroxychloroquine as well as a triple combination where there's clear data in a Chinese population for the value of hydroxychloroquine and a value of mycophenolate. That would seem to me to be a potential combination approach. Not for me, because my patients are Caucasians and we don't have that data yet. So I think I would see those combinations working. Whether we would want to combine any of the newer therapies, I think we need to just know the safety profile first. But I'd be interested what you think about combining gut-directed steroids with hydroxychloroquine and mycophenolate.
Well, I know hydroxychloroquine is widely used across many parts of China. In my part in Hong Kong, we do not use hydroxychloroquine as a routine. So many of our patients don't get hydroxychloroquine. Quite a number of our patients receive mycophenolate, and many patients in Asia, I believe, also receive mycophenolate. So in terms of combination, I think we have yet to see the arrival of these therapy, which have largely not arrived. They have only arrived, online, where we read about them, we learn about the trials, but I think it takes time, for us to learn how to use these drugs. Obviously, I think there are a number of therapies which are available, including not just Nefecon, but also tacizap in many parts of China. So following on this question, Jon, you have also talked about the huge armamentarium of therapy that may be coming along, including killing cells using, cell-killing oncological type of approach. What do you think is the prospect, of using these therapy for our patients?
So I think we're going to need to have lots of choices. I think that if you think about a 30-year-old that is young and fit, most of these therapies, I think, are going to be absolutely fine. Think about that 30-year-old in 20 years' time when they've put weight on. They now have diabetes. They may have cardiovascular disease. The risk profile for the same person as they get older is likely to change. And we may well need to change the way we treat the IgA nephropathy in that person because the risks of treatment have changed as that person has got older and gained more comorbidities. So I think we need to move away from the idea there is one wonder drug that is going to work in a person when they're 30, and we're going to keep using that drug until they're 70 or 80, because risks will change. And so I think we need choices, and I think we may well want to take a more aggressive killing approach, potentially, in people that have a different risk profile to people where we might want to take a slightly different approach, where we can stop and change treatment quickly. So I think all of these treatments are going to have a place, but I think, and I come back to this, the treatments I will choose for my patient when I make a first diagnosis are likely to be different in Leicester than the treatments you two will choose in Taiwan and Hong Kong, and the treatments Hitoshi will choose in Japan, because our patients are very different. And I think the combinations we choose will be different, and how we change treatment over time will also be different. And that's absolutely fine. But we can't all say you have to treat IgA nephropathy one way. And we are going to need to have choices, and we're going to need to tailor the choice to the patient. And I think Chee was looking at that was the case that Chee had, where it's a young person, where you're going to have a conversation with that person and give them treatment choices. It will be different for different patients. And I think that's going to be the same for you, Hitoshi, isn't it? You know, your choices for a Japanese patient will be different, I think, to my choices.
Okay, thank you, Professor Barratt. There is a question for Professor Cheng. Most recent trials don't take account hematuria into study. How does the presence of hematuria affect your treatment decision?
Yeah, I think a very interesting question. We've actually been asked to write a debate article on this recently. So I think up to now it's been quite easy because we've not really had therapies that can affect hematuria that effectively. And it's clear that patients with IgA nephropathy, that hematuria is a presenting factor, and we don't tend to biopsy patients with just isolated hematuria, no proteinuria, normal kidney function, because we know those patients have a very good outcome as well. And we know also from the trial data that there are probably a proportion of patients who will have persistent hematuria, that no matter what kind of treatment you give them, they may always have hematuria, and maybe that's due to glomerular filtration barrier damage. They could have type 4 collagen mutations underlying that are causing microscopic hematuria as well. And the other point is that I think that we have to get a lot better at analyzing hematuria in a more reliable way as well, because the tests that we have at the moment are fairly unreliable. So I wouldn't really use that in isolation is my answer, but I think coupled with measures of proteinuria, kidney function, and taking that as a whole combined approach would be the way I would approach it. I think it's going to be very interesting with the new therapies now that can actually reduce hematuria. So we're seeing that come through with the complement therapies, with the anti-APRIL, anti-BAFF-APRIL therapies as well. And maybe if we're thinking about pausing or giving patients a treatment break, maybe if patients' hematuria goes from a high level down to completely negative, and then it re-emerges at one point, that may be some kind of indicator, along with those other factors, and thinking about, for example, IgA levels as well, to restart your treatment. But again, I'm just kind of hypothesizing here. I think those will need testing in more detail as well. But I'm obviously interested in my co-panelists' thoughts on that.
Thank you.
So I know not all centers would look at hematuria in a routine fashion, but I know that in Japan, hematuria is very much looked at. So this next question is directed to Hitoshi, Suzuki. So what is the utility of using hematuria in guiding therapy? In particular, how do we choose the different biologic treatment for IgA nephropathy, particularly with regard to complement mediated or related type of therapy that you have described?
Okay, yeah, we usually see the microscopic hematuria so using the flow cytometric analysis. So, and we could find early stage of IgA nephropathy. So there is a paper from Japan that just isolated hematuria with no proteinuria. In such a cases, they diagnose IgA nephropathy. However, the severity IgA nephropathy is indicated about 50%. So showing the crescent or end capillary proliferation. So then we would suggest microscopic hematuria. I mean, the glomerular hematuria is one of the marker of activity of the IgA nephropathy. So, but as Chee suggested, not only the microscopic hematuria, but we need to think about the proteinuria and eGFR decline. So the basic treatment is in IgA nephropathy is reduction of Gd-IgA1 immune complex formation. However, during the treatment of the upper pathogenesis of IgA nephropathy, so if we cannot we cannot satisfy the hematuria, proteinuria, or eGFR decline. In that cases, we can use a complement inhibitor. And also the cases with APCN or cases with IgA nephropathy, in that case, it's also the good option for the complement inhibitor in the first step.
So Hitoshi, may I just follow up? So complement inhibitors sometimes would require vaccination for obvious reasons, right? So do you think complement inhibitors can be used in combination with some of the immunomodulatory or suppressive agents, such as Nefecons, such as systemic corticosteroid, or even the BAFF/APRIL inhibitors?
Yeah, it is a good question, but we don't have any data. So actually, the complement inhibitor is not approved in Japan. So, but theoretically, if the patient with inject with some, I think the 3 vaccination, in that case, at least the data from iptacopan data, so there is not significant difference between iptacopan groups and placebo groups. So it might be, so we need to take care for the patient very short duration. So I think that it's not a major option for the, we can combine with the other immunosuppressant therapy with complement inhibitor.
Thank you, Professor Suzuki. I also have has a question for you. From a practical point of view, which clinical features or complement biomarkers or renal histology findings would make you think that this patient is majorly driven by complement activation. Therefore, it's a good candidate for complement targeted therapy. So, which markers do you think is most important for use of complement-mediated drug for IgA nephropathy?
Yeah, it is very important, but just now we don't have any clinical data for the complement activation. So in the research area, so we can measure the factor B or factor H and FHR. So, but in clinic, it's not available right now. So, but it is our urgent task to establish the measurement of the complement system in the serum and urine.
Yeah, I think just to add to that, your question was about biopsy features. And I think we saw from the applause subgroup analysis of iptacopan that even if patients had hematuria or no hematuria on dipstick, or they had inflammatory lesions, M, E, and C scores versus no M, E, or C scores, the patient still benefited from iptacopan in terms of reducing proteinuria. And maybe complement is having an effect on driving tubular interstitial inflammation and fibrosis as well. So I think it's very difficult to kind of correlate those biopsy findings and treatment responses at the moment. I think we don't really have the data to support that. But bearing in mind the caveat that some of these patients may have had biopsies sometime before study entry as well, so there could be a delay between the biopsy and starting treatment in the study.
So I have a question for Jon. So you've presented data on PROTAC and ALIGN. How would you make a choice, putting a patient on DIRA or atrasentan plus an ARB? What is the thinking process?
Well, I think we need to see the GFR data is the important thing. And I think for any drug, the treatment decision is made first on safety, second on efficacy, and third on patient convenience. And I think if we think that safety and efficacy are similar, then it's a very simple thing. You offer the patient to take 2 tablets a day, atrasentan on top of their normal RAS inhibitor, or you offer them 1 tablet a day with a combination treatment. And I think some patients will be happy to take 2 tablets and some patients will be happy to take 1. But I think you have to drive clinical decisions based on, firstly, safety, secondly, efficacy, and then patient preference. And then, of course, depending in the healthcare system, the thing that you mentioned, Chee, which is the cost. So in the NHS, which is what I work in, if one of those 2 is far cheaper than the other, we will be using the cheapest one. So that will be another factor. And I think that's, I'm seeing people nodding. I think that's the same thing that you'll face wherever you practice medicine. And that's the way I think we should be viewing these new therapies.
Okay, thank you. I have a question for Professor Barratt. With the deeper B cell or immunoglobulin suppression, many clinicians are concerned about the infection and the vaccine response. So which kind of monitoring strategy do you recommend when use such a BAFF or APRIL target drug? Yeah.
So the question is, should we be monitoring in any particular way?
Because of the possibility of infection or vaccine response decrease. So yeah.
So if you look at the data presented at the ASN and in the 2 New England Journal papers for both an APRIL-only approach and a BAFF and APRIL approach, the safety profiles were incredibly good. There were no deaths from infections. There were no serious adverse events due to infections and no new opportunistic infections. So from the perspective of the clinical trials, there were no notable infection risks. Bearing in mind, this is 9-month data in a relatively small number of patients, but the safety profile looks incredibly good. Compare that to the testing trial, where they had to stop the trial because of deaths from opportunistic infections. And I think as clinicians, we're all used to using systemic doses of steroids. But actually, the safety profile for systemic doses of steroids is far worse than what we have at the moment available for BAFF and APRIL-only inhibitors. Now, the couple of things I think we need to think about. The first thing is there was an IgG cutoff for all trials involving APRIL and BAFF and APRIL inhibitors. So if your IgG was below a certain level, you were excluded. That level of IgG cutoff was different in the different trials. We need to think about how the drugs were used in the trials. So in some trials, there was a protocol that if the IgG was falling, you would reduce the dose or you would hold a dose. We need to have that information to know how IgG was looked at and whether we need to alter treatment based on IgG levels. In the trials, IgG was measured regularly. Is that what we need to do in clinical practice? Do we need to hold a dose of these treatments if the IgG is falling to 100 or whatever that value happens to be? So I think we do need to learn. And in fact, we're going to have a conference in the United States next year where we're going to look at developing practical guidelines for how we use B-cell therapies. Do we need to measure IgG before we start? How often do we need to measure IgG when you're on? At what level of IgG do we need to be worried and to hold a dose? Because those are things we actually need to know if we're going to use them. And we don't have any guidance at the moment. And if you look at the label for sibeprenlimab that the FDA have issued, it doesn't help either. So we're going to need some practical guidance. And that will hopefully come about next year.
So thank you, Jon. And with that, that brings us to the close of this session. I'm sure you would agree with me that we have learned a lot from this KDIGO session on IgA nephropathy. So please join me again to thank all the three speakers on stage.